Hello, welcome to this introductory presentation on Dementia and Continence. My name's Lorraine and I'm one of the Associate Practitioners with Dementia Carer Counts. With this presentation and our one-day course, we are hoping to facilitate carers to support the person with dementia maintain their continence for as long as possible and to inform them of things that can be put in place to eliminate or minimise problems when they occur. For our organisation, it's also important to raise awareness and empower carers to voice their own feelings and emotions and find ways to sustain their strength and resilience in the caring role. We hope you'll find this introductory session helpful. There will be a follow-up one-day course. You can find out more about this on the website. There are different types of continence problems affecting either the bladder or the bowel. Urinary incontinence can present in different ways. An overactive bladder is more commonly seen in dementia. Other things that we see are urge incontinence, which is an inability to retain urine until reaching the toilet. Stress incontinence, which is a leakage of urine when coughing, sneezing, or when exercising. Overflow, which causes leakage when the bladder is full. And nocturnal enuresis, which is leakage of urine during sleep. Fecal incontinence is less common. The types are passive incontinence, where there's a lack of awareness of discharge of faeces, urge incontinence, where the person is unable to retain faeces despite attempts, and seepage, which is leakage after emptying the bowel. The Collins English Dictionary states, if something has a stigma attached to it, people think it's something to be ashamed of. It's hard to believe that this statement could apply to people living with both dementia and incontinence, but there remains a great deal of stigma surrounding both conditions, the last medical taboos. The stigma may not just affect the person with the condition, but can also affect the carers by association. The combination of these two stigmatising conditions may lead to oversights and omissions in integrating services linked to mental and physical well-being. Research has also shown that carers can sometimes be reluctant to seek help for continence problems due to their concern about the dignity and personhood of their loved one. It can be helpful to try and break the vicious circle of stigma by addressing continence problems in a pragmatic and direct manner. It can help others to do the same. However, it is important to find the right level of openness required in individual situations. The move from supporting with personal care to providing intimate care can have an emotional and psychological impact on the relationship between the carer and the person with dementia. Very often carers believe it's their duty to provide this type of care, but their feelings about undertaking it are not always addressed effectively. Cultural expectations will influence and differ from family to family. However, gender often influences expectations. For example, should sons assist their mother? Should it only be females who provide this type of care? These are good questions, and there's not always a simple answer. Depending on the nature of their relationship with the person that they're caring for, some carers may find it difficult, if not impossible, to cross certain boundaries linked to continence care, such as seeing the person naked, intimate touch, or hygiene challenges. And some male partners are reluctant or unable to provide this type of care at all. We must also remember that the person with dementia may also feel uncomfortable with receiving personal, intimate care, and they may struggle with the loss of privacy and dignity. However, situations arise and the carer may have little choice, putting them under tremendous physical and emotional pressure. An individual may find it acceptable for a professional carer to ask about bowel movements and prompt them to go to the toilet, but if this is done by a family member, they may find it humiliating and see it as threatening their adult status and dignity. This can lead to arguments and conflict, which can make the situation even more challenging. To maintain dignity for both parties, it's important to focus on the persons with dementia's strengths and the things they're still able to do and encourage this, even if it makes the process longer. Spouses and partners providing intimate continence care may lose their attraction and be reluctant to engage in a sexual relationship with a person with dementia. This can result in both losing out on the benefits of this type of relationship. If this is the case, there are services such as psychology, counselling and sexual health that can be helpful in finding solutions. There are certain things that we need to take into consideration in relation to dementia and maintaining continence. These are normal ageing changes, brain changes due to the disease process of dementia, frailty and multiple health issues, and medication. Dementia causes multiple brain changes that over time can have a major impact on daily functioning. Most older people are dealing with more than one health condition. The older the person, the more likely they will be dealing with multiple comorbidity, and more than half will have 3 or more conditions. Dementia and incontinence can be part of a syndrome called frailty. With frailty, there is often muscle weakness, problems with endurance, balance, mobility, and nutrition. Other common conditions that can impact on continence in older adults are diabetes, cardiac failure, joint disease and arthritis, chronic lung disease such as COPD or emphysema, Parkinson's disease, depression, and stroke. Up to 45% of medications are prescribed for people over the age of 65, and about 1/3 of older people are prescribed 5 or more medicines. Due to the high prescribing in this age group, it's essential for a person developing urinary problems to have a full medication review, preferably by a pharmacist. In terms of continence issues, there are some medications that may contribute to incontinence. Some of the more common are diuretics or water tablets, antihypertensives for treatment of high blood pressure, antipsychotics, which are major tranquilizers, anti-Parkinson medication, and some antibiotics for treatment of UTIs in women can have a side effect of cystitis. Drugs prescribed for Alzheimer's disease can cause or worsen incontinence and can cause particular problems with control of the bowel. The main type of drugs used to treat urinary incontinence have been shown to impact on cognitive impairment. So why do people with dementia find it difficult to maintain continence? As well as dealing with the normal ageing changes, the person with dementia will be dealing with the adjustments to cope with the brain changes due to the disease process. Visual changes may affect their ability to recognise a space or facilities, read signs, or distinguish colour contrast. Language can be compromised and the person may have expressive difficulties where they struggle to communicate the need to use the toilet, or they may have receptive difficulties and are not able to understand a verbal prompt to use the toilet or understand they need assistance. Sensory changes can affect the person's ability to recognise the message from the bladder to the brain that would alert them that they need to use the toilet. Memory and orientation are often affected in the early stages and can mean the person is unable to remember where the toilet is and how to navigate to get there. Changes on mobility and judgment can lead to problems such as being able to determine distance or the time to get to the toilet, which can lead to accidents. Other examples of this are being able to judge the height of a step on a stair, which can increase the risk of falls. Dark patches or shadows may be perceived as steps or holes, deterring the person from moving forward. The person's spatial awareness changes and they can have difficulty in understanding how things fit into a space and with coordination of body parts, for example, sitting on a toilet or putting a leg into a trouser. To complete the process of toileting, a person requires to retain the motor skills needed to open, lower, raise, replace and fasten clothing, which is quite complex, and any part of that process can be affected by the brain changes. They may be unable to recognise objects in the toilet or how to use them. They may urinate in inappropriate places like the sink or the wastepaper basket, mistaking it for a toilet. They may not clean themselves properly because they no longer recognise toilet paper and what it's for. This may lead to the person trying to dispose of faeces when they may not recognise it or what to do with it. They may try to hand it to the carer, They may use objects in the toilet to wipe faeces from their hands, smearing surfaces such as sinks, walls and floors. Loss of motivation and volition to use the toilet can be related to depression. It's not always due to the progression of the dementia, therefore it is worth having this checked out. It's important to try and see things from the perspective of the person with dementia who may be struggling with incontinence. Resisting support may be due to embarrassment or their own attempt at maintaining their independence and dignity. To avoid having someone assist them, the person may try to manage the process themselves, resulting in hiding wet or soiled clothes by putting them out of sight to be dealt with later, but then forgetting, causing odour to develop. To minimise the need for such intimate care, it's important to focus on what the person can still do and actively encourage this in order to preserve the person's skills. It may be that a prompt or showing the person what needs to be done by mimicking the action is all that's required. This may result in the carer only needing to provide support in certain parts of the process, and the person is able to complete the rest. 24-hour monitoring and constant vigilance with continence care may take a toll on the well-being of the carer through exhaustion and neglect of their own health issues. It can often seem like a never-ending process of changing pads, personal care, dealing with washing and maintaining the environment. This leaves little time or energy for the carer to recharge their battery and often results in them losing their support lifeline. Some carers feel the incontinence issues can take over their lives and may arouse fears regarding the progression of the disease, as it may bring home to the carers the progressively worsening condition of the person they love. They may also have feelings of guilt and disappointment in their inability to cope with the situation or for considering the option of respite or longer-term care. Providing intimate care can cause some carers to experience feelings of humiliation, disgust, or they may actually feel they're doing something immoral. This can be compounded if they are also experiencing continual resistance and conflict when trying to support the person with their continence problems. It's not always easy for a carer to share with other family members that their loved one is having continence issues, or that they need help in managing it. There may be a cultural reason for this, or there may be difficulties related to the previous relationships. In some cases, the carer can lose their own community connections and social contacts, resulting in feelings of loneliness, isolation and depression. Access to continence services can vary across the country, as does the supply of products. It's also important to be given training in how to use the products correctly to ensure they work efficiently. Environmental adaptations can vary in cost from minimal to expensive refurbishments. Local authorities can assess and advise on what help you are able to access. Many thanks for joining us. We hope you found it helpful. As mentioned at the beginning of the presentation, there will be a follow-up one-day course. You can find out more about this on the website.